Hello, my name is Dr. Fred Sylvester from Hanover Chiropractic, and welcome to this episode of Health Talk. Today we have a very distinguished guest, Dr. Glenn Lipton. He is owner-operator of Premier Orthopedist. Graduated from Temple in 2001, Drexel in, I think, 2005, somewhere in that area?
2006, yes.
Yeah. And he's been servicing our area orthopedically since 2006. He's brought a great deal of respect and integrity back to the orthopedic world. It's been a pleasure to work with you over the last few years here, and I look forward to having this interview with you. So, Dr. Lipton, we're going to now talk about the knee. And, you know, the knee has sometimes is very vulnerable for injury. So we're going to talk about meniscus and meniscus tears in that. So again, let's explain the normal anatomy of a knee.
Sure. The normal anatomy of the knee. First, we'll start with the bones. So you have the shin bone, which is the tibia bone, which is the bottom bone. You have the top bone, which is the femur, or the thigh bone. And you have the fibula over here. If you look carefully at the knee, we're going to talk about the meniscus, which is in between both of those bones. That creates the shock absorber of your knee. It's made of cartilage.
Sure.
And that particular shock absorber can get injured with twisting motion. So that's why we're going to talk about it. If you looked at the number of knee arthroscopies in the United States of America, it's one of the one of the most commonly performed procedures in the entire United States of America. So understanding the anatomy, understanding the injury is important because many people have meniscus tears and they sustain these injuries to it, and they need to understand about how we treat them and what the pathology of it all is.
Okay. So again, the meniscus is basically a shock absorber that sits between the two.
Correct.
All right. So how would a knee get injured? How would a meniscus get torn?
So typically, we break down the meniscus injuries according to the age. For a younger person, you know, it's more of a traumatic event.
Okay.
They're playing a sport, they have a twisting injury as they go down, and the femoral condyle bangs into the meniscus and twists and hits it and creates an injury. Here's the femoral condyle, and when it creates these injuries, you can see this is a bucket handle tear. This would make the meniscus tear in the middle there. It kind of looks like a bucket handle.
Sure.
In that particular injury, the bucket handle tear, if it's in a young person and the tear is in a zone where there's a good blood supply, we like to repair it. And in those situations, when we repair it, we put sutures into that region. And what ends up happening, if there's a blood supply, it typically heals. As we get older, the blood supply regresses back in the meniscus, and we can do less repairs, but we still can treat it with meniscectomies where we just trim it back.
I think we should just pause right there and let's kind of look at what the difference between a repair is versus mastectomy and that type.
And that's going to be also based on the anatomy, so we can talk about that. In the meniscus, as you get into the middle of the joint, it's in the middle right there, and then you get more either outside of the joint. There's more blood supply on the outside than there is on the inside. It's a very thin triangular type shape if you took it in cross section. That particular part of the meniscus where it tears most frequently is in the area where it's the thinnest.
Okay.
It also can be weaker because of age, degeneration. It gets weaker as we're using it all of our life. So the shock absorber effect, the constant pounding, we can see more tears. So the anatomy of the meniscus leads to where the tears are, not only within the meniscus, but also on the side. So you have an inside of the knee, which is the medial side, and the outside, which is the lateral side. And specifically, the lateral meniscus has a greater excursion. It moves. So we can take the femoral condyle, the thigh bone, moving it more because it's able to move more.
Sure.
The medial meniscus is anchored more tightly onto the tibia bone. And so what ends up happening is when we have an athlete twist with the femur bone, the medial meniscus is far more prone to an injury than the lateral meniscus. The lateral meniscus will move a little
bit.
To it. Correct.
Interesting. So when we're talking about how most people injure meniscus, is it usually acute trauma or is it just usually wear and tear?
So acute trauma for the younger population and wear and tear in the older population.
Okay.
And so what happens with the older population when they have that acute tear, or they have the wear and tear injury, and sometimes they'll have an acute one as well. But for those people, it's less of an acute injury, less force, because the meniscus is weakened already just from normal everyday wear and tear and degeneration. Those folks, we try to treat them on a conservative basis in the beginning. We discuss everything, but we also preface our conversations with the patients that, hey, this won't heal. In a patient of that age, you know, the blood supply's regressed. We know it's not going to heal, but if we can get that meniscus to not hurt, and we don't do surgery, that is a win. That's what we want.
So what would you say the prevalence is of, meniscus tears and that type of stuff when you're looking at it from your own, experience in practice?
So it depends what the age is. I think the prevalence of the tears in the older population that have a little bit of arthritis and they're active is quite high.
Yeah, I think it's 60% of
it is. But the issue is, and so it doesn't mean they're all going to get surgery.
Okay.
It means that they have the option, of course, if their pain persists despite the conservative treatment. Most of my patients at least try to do the conservative pathway. I try to focus them that way in the older population. The younger population, for instance, in a young person, in the teens and early 20s, I try to focus them on getting them repaired, and here's why. Yeah. The meniscus, it's the shock absorber, and we do want it to survive. So if there's a chance of actually suturing it down and getting it to remain a functional shock absorber, that's important. They've looked at people in the past who had a total meniscectomy done. Back a long time ago, that was the thought. They thought the meniscus was not an important structure, that it was vestigial. So they would just cut it out if there was a tear, and they would let the patient go. But what they did is they followed these patients out. They've done studies, and they figured, well, they identified that if you take out the entire meniscus, that side of the knee where you took it out gets significant severe arthritis very much earlier than the other side, and those people then need a knee replacement very much earlier. So our goal as doctors, surgeons, is to go ahead and try to make it so they don't need such an invasive surgery. So if I'm just going in there throwing a few sutures to repair it, a young person, you really want to do that. You don't want to ignore that. You want to get it done. Right. Now, on the other hand, if a patient's 65, 70 years old, they tear their meniscus, and they failed the conservative measures, I say, yeah, we can cut it out if it's causing you pain, because they're already at the point where, okay, if it causes earlier arthritis, and arthritis is in 5 years, you get a knee replacement at that point. It's not a real major loss. You don't want it to happen, but it's okay. So and they don't have a blood supply, so you really couldn't throw sutures in. Gotcha. So when I see a patient as I'm examining them and I bring them into the office, I do a good exam, a good physical, and I explain to the patient with their history, what the next steps would be in every step of the way. The first one is again going to be an X-ray. I want to see, is the knee pain that they have, is it truly a meniscus, or is possibly there a lot of arthritis there as well? Sure. If there's severe arthritis in an older patient, even though they have a meniscus tear, I would probably not recommend arthroscopic surgery because I know they need a knee replacement anyway. Then I would focus them towards the other pathway. It would all be conservative treatments in the beginning. Again, a steroid shot into the knee, and anti-inflammatory rehab. That all works. And if the patient is good, we don't do anything else. If they continue with pain, then we discuss, would you do a knee replacement? What is
I'll say the primary symptom that a person presents when they have a knee condition of a meniscus attitude versus runner's knee?
Yeah, so the symptoms, I like to correlate that with the history. So usually what I'm hearing is it's a twisting injury. They hear, sometimes they'll hear a pop. And then I ask them, I say, well, when did you experience any swelling? Was it immediate? Was it within 24 hours? Or was it gradual? It was swollen already? And that kind of guides my way. So if it's immediate, I go, well, maybe it's not just the meniscus. Maybe their ACL disrupted, in which case it's a little different treatment protocol. If it's within 24 hours, they had a pop or a snap or a searing pain when they did a twisting motion injury, then I say to them, okay, at this stage, I think you may have a meniscus tear. If their knee is swollen, usually the meniscus tore, it's a big tear, and there's some bleeding now, and that's why it's swelled like that. If they've had swelling persistently, that's usually someone that's more of an arthritic knee, because that's been chronic there.
All right. So from that differential diagnosis standpoint, then that allows you to start making your decision, formulating your treatment plan of how you're going to look at. So say we come to the conclusion that, yeah, this is 100% meniscus, medial meniscus, you identified it. What's the procedures? What do you do?
So usually it's an arthroscopic procedure. I don't know of anyone who's actually doing open meniscectomies currently. That was done, as I said, in the distant past. So it's arthroscopic. It's just little poke holes. We go into the joint. We visualize everything. In my particular practice, I look at every single joint surface and I grade the arthritis under the kneecap, on the top part of the femur, on the inside of the knee, on the outside of the knee. I want to know exactly what it is because post-operatively, I present my patients with their pictures and I grade the arthritis in every compartment. I also then look at the meniscus. I look at the ACL, the PCL, and every structure inside the knee. After I identify the meniscus tear, if I'm in the medial side of the joint, I look at the tear. I figure out which one it is. Is it a tear where there's a flap into the joint, that's in an area of no blood supply. That particular tear is, we perform a meniscectomy where our arthroscopic scissors come into the joint and we trim it back. And I have a picture of that.
Sure.
I'll show you that. So there's the bucket handle, there's the radial tear there. And here's a complex tear where it's not, there's no other specific orientation of the tear, just complex.
Sure.
Now here's the arthroscope into the joint, and we're looking at the tear, and these are the arthroscopic scissors in there. And this is the actual picture of the surgery being performed. Here are the scissors working, and we just trim it back, and we want to recreate that semicircular shape.
Gotcha.
This is where we actually do the repair. Notice that the tear is on the periphery where there's a good blood supply. That area, that will heal.
Okay.
So when we get into the joint, we look and we assess the tear. And we go ahead and we put sutures in if we can repair it in a younger patient. And the older patients, we actually trim back the tears because those can't be repaired.
Gotcha.
The other caveat to it is when we see someone in the office, if they have a locked knee where they can't flex or extend, usually a little piece of the cartilage of the meniscus is blocking the normal motion of the knee. In that patient, it's not really an emergency, but it's something we want to act on relatively quickly because we don't want them to get a permanent contracture.
Gotcha.
So we don't leave someone with a tear that causes a locked knee for long.
Sure.
The other thing that patients will complain of catching, where the flap is going in and out.
Okay.
So those people have a little bit more time, and they can do, they can address their tear on their own timeline. But the ones that have, a tear that causes a locked knee, we try to focus those folks on getting to the operating room to get unlocked and get that thing repaired very quickly.
Is there any concerns that a patient would choose not to do that? What would they have to be aware of if they chose not to repair their meniscus if it's torn?
Yeah, I mean, I tell people if it's a locked knee, I say, look, here's what the complications could be. You could have a permanent loss of motion. But in the case where it's just a tear that causes intermittent pain, I tell them it's really up to you. You don't have to do it.
Sure.
It's really based on your symptoms. So
Gotcha.
if you're just having pain and discomfort, and you are tolerating it with, say, an anti-inflammatory or repeated shots, every 4 to 6 months. I understand that, and I don't ever force anyone into surgery. I always would want them to say, okay, I'm happy where I am, or I need to, plan for surgery if they're not happy.
Okay.
The only times where I kind of really push a little bit is the younger patient that has a repairable tear, and anybody who's got a locked knee, because we don't want to have those long-term complications.
For sure. Are there any pre-existing conditions that make a person more susceptible to a meniscus tear? Weight?
Yeah,
age?
Age, definitely, because there's the degeneration factor. Weight is going to be a big concern too, because there's more pressure on the meniscus, and if they have twisting motions with more pressure, it's a higher prevalence of a tear.
Okay.
I am a big fan of trying to tell people who smoke not to, because there's the blood supply issue, and we know smoking affects blood supply, and the less blood supply, the weaker the meniscus is as it regresses. So I try to get people out of that, and so I think that that's very important. And also for healing, if you do go to surgery and you're smoking cigarettes, it decreases your healing potentials.
What about, and this pains me to ask you this, but as a runner, are runners more prone to meniscal tears and everything else like that in your experience?
So runners, if they're running and they're careful and they're in a straight line run and they really don't do much of any aggressive running, they do okay, but there is an increased incidence because you're pounding your knee more.
Sure.
So, but I don't tell people not to run unless there's other pathology in their knee, for instance, arthritis.
Okay.
And the reason I don't do that is because the benefits of running are very, very good.
Sure.
Now, I will have a patient readjust their activities. In fact, I just operated on one literally 3 hours ago who's a big runner, 7 miles 3 times a week he ran.
Yeah.
And he had meniscus tear as well as arthritis. And my conversation with him after surgery and with his wife was, maybe we need to modify your activities. But I went to him beforehand too, so I'm beginning to introduce this concept to him. Hey, we're not going to take your activity away from you. I just want to modify it a little bit. Run once a week, maybe do some swimming or recumbent biking, things that are a little bit better for the knee.
Right.
And on my nightly call, I call all my patients after surgery. Tonight on my phone call, I again will gently introduce that, because runners who do it all the time don't want to change their ways. But his particular arthritis, and very often when I operate on these, I see a significant amount of arthritis from that running, worse than I would in someone who did maybe an athlete that swam all the time. Because there's less impact on it.
So when you're looking at this from that perspective, you know, certain things that might create or predispose people to it, what is your success rate? You know, when you look at, when you do a meniscal repair, are you 60%, 80%, 90%, 100% success? Where do you typically sit?
So the success rate is very much based on expectation.
Yes.
And here's why I say that. If I have a patient who's an older patient, the gentleman I did this morning was 50 years of age. His specific knee, for the standpoint of the meniscus work, is going to be very successful. He's no longer going to have that sharp stabbing pain where the meniscus was, because I took care of it.
Yes.
I trimmed it back. I took pictures of it. It's gone.
Right.
On the other hand, on the other side of his knee, he actually had significant arthritis.
Sure.
So if you base your success rate on is all the pain gone in the knee, it may be much lower than really what would happen.
Gotcha.
I tell people, look, I know I can get the meniscus pain to go away because I'm going to trim it back and that's going to be gone. The issue is there other problems in the knee? And so to say there's a success rate or not, it's very difficult. The literature out there doesn't purely look at patients with only meniscus tears.
Okay.
If you look at it like that, it's very high. For instance, my younger population, who I do meniscus repairs and meniscectomies in, if they're irreparable, it's amazingly high.
Sure.
Those people go away very satisfied. And actually the population with arthritis that has it as well, I spend a lot of time talking to my patients, so they completely understand, and their reported success rate is going to be much higher than you would expect, because they know, okay, here's the meniscus pathology. I spend the time. Here's what the meniscus tear causes in this type of pain, and here's what the arthritic pain is like.
Yes.
And so as long as you explain to them, they're very, very happy. And then I also tell people, if there's a significant arthritis, I go, look, you have a meniscus tear, you have arthritis. I can take care of the meniscus. I can cure that. I'm going to trim it out. That's not a problem. It's the arthritis. You will need shots in the future.
Gotcha.
I'm certain of it. Because I've done a significant number, and I have a large population of people with both.
Gotcha.
And so I very much tell them. And interestingly enough, the MRI doesn't always show the arthritis to the degree.
Until you get in.
Yeah, in fact, I tell my patients, I go, look, I've never come out of the operating room and talked to the family and the patient and said, hey, guess what, good news, there's less arthritis in the knee than was on the MRI.
Yeah,
it's always the other way around. But I tell them about that. I say those words exactly, and those patients understand, and it ends up being an understanding, and so they understand what the next steps. And usually they're very receptive to modifying the activities a little bit, such that they can get the maximum benefit out of it. When we're in the operating room and they have the arthritis as well as the meniscus tear, we do treatment to the arthritis when we're there. We don't leave the fragments of cartilage coming off the bone. We trim them back. It's called a chondroplasty. We clean all that stuff up, and in certain cases we can do other things to those cartilaginous defects. You know, if it's a young person, I actually do a cartilage transplant. It can happen. And for the very young people that have a complete loss of the meniscus because it's not a good blood supply, those folks actually get a meniscus transplant.
How about that?
Yes.
So in the end of this whole thing, what's your take-home message for knee pain?
My take-home message for knee pain in general is this. You don't have to live with it, number one. If you have knee pain, it's affecting your daily activities. You're not able to do your exercise that's good for you, or you're not able to do the normal things that you'd like doing, come into the office. First, I think exercise is a very good health benefit. So if you have mostly arthritis, the exercise and the rehab that you provide is an excellent way to start. If it doesn't improve, or if you have sharp stabbing pain that won't allow you to exercise, come into the office, get evaluated, see what your true pathology is, and come up with a plan. If you can be treated conservatively, that's the goal. And if you can't, and you need to get surgery to restore your normal life, you should consider it, because you don't want to have all of the negative benefits of not exercising and keeping a healthy lifestyle.
Excellent. So Dr. Lipton, thank you so much for coming on to our show. Great information, second to none. And again, I think I'll say the amount of respect that the local medical community has for you and what you do in this area is second to none. Really appreciate it.
Very much my pleasure.
Good day and good health.